This is a composite of both the standard global dinner series that is between MGH and Boston Medical Center, but also something that's within our residency program, which is our global pathway or global local cultural pathway of residents who have a particular interest in this field. And so we've kind of combined forces this evening, and we are going to have two of our T32 fellows presenting on their work. So I will briefly give an introduction. Amelia Stanton, psychologist, is in her final year of the T32 training program. She completed her predoctoral internship at the behavioral medicine program at MGH and her doctorate in clinical psychology from the UT Austin program in 2019. Her research is focused on sexual health disparities among women and historically marginalized groups. And so she'll be presenting on some of that work as it relates to, I think, HIV and mental health in South Africa. And then Maria Prom is another one of our T32 fellows, also based at MGH and Harvard Medical School. She is an MD from Vanderbilt, completed psych residency with me at MGH McLean. Always a pleasure to see Maria. And then continued on to her CL fellowship there. So her research is focused on mental health systems and services in low resource settings. In particular, she's been doing work in Peru, and similar to Amelia, it will also be presenting on some of her women's mental health work today. All right, I'm not sure which of you is going first, but feel free to take it away.
I can go first. I think I was listed first, but I don't know if that really matters. Let me see if I can figure out how to share my screen here. That is not what I want you to see. Can you see PowerPoint at all, perhaps? No.
We can see your PowerPoint, but it's still in sort of standard mode, not in presenter mode yet.
Got it. Okay, thank you. How about now?
It's now in presenter mode.
Okay, perfect. Okay, so thank you so much for having me. Today I'm going to be first moving this bar of my face so that I can, there we go. Today I'm going to be talking about mental health and HIV prevention among pregnant and breastfeeding women in South Africa, mainly as a vehicle for talking about the work that I hope to do through a K23 and the work that I'm currently doing through a small grant that I got from Harvard CFAR. So thinking critically about sort of psychological barriers to better sexual health, to more agency and management of sort of sexual health outcomes among women. So again, thank you for having me. Okay. All right, so South Africa has the largest number of people with HIV in the world, about 7.5 million people living with HIV in South Africa, and women of reproductive age are disproportionately affected by HIV. In 2019, women actually accounted for 65% of people with HIV in South Africa, and new infections among young women are almost double those among young men. So about a difference of, oh, can you hear me? Is that from my end? Oh.
I muted a couple of people, so hopefully.
Okay, it sounded like
unmute folks when you
I had a vacuum on the, which would be probably, I don't know if that's preferable to listening to me talk about this, but thank you so much. So yeah, I was saying that in 2019, women accounted for about 65% of people living with HIV in South Africa, and new infections rates are really quite astronomically different between men and women, with 120,000 new infections in men in 2019 versus 66,000 in men. And if I said men before, I meant women, sorry. So importantly, the rate of decline in HIV incidence has been significantly lower in women than in men. And worldwide, we know that AIDS-related illnesses remain the leading cause of death for women aged 15 to 49. So this is still a huge problem. We do see decreases in prevalence rates, which is wonderful, but at the same time, this group is still deeply affected. the risk of HIV acquisition during pregnancy and the postpartum period is incredibly high relative to periods in which women are not pregnant or postpartum. And an interaction of biological and behavioral factors exacerbates risk during these periods. So we see high levels of estrogen and progesterone inducing changes in the genital tract, which increase susceptibility to infection, and condomless vaginal sex during the postpartum period, which in this population may resume as soon as 2 to 4 weeks after delivery, can also increase risk. And HIV acquisition during pregnancy and breastfeeding increases perinatal transmission, which actually accounts for up to 30% of new infections. And with global breastfeeding targets up to 24 months and beyond, postnatal transmission is a large and growing percentage of HIV transmission. And it accounted for 75% of all mother-to-child transmission from 2017 to 2018, which was up from 40% in 2004, 2005. So those rates are increasing. It's important to be aware of this group at risk here. So that takes me to PrEP and adherence to once daily oral PrEP, either TDF-based or injectable cabotegravir PrEP, trial recently published, effectively prevents HIV acquisition. And we know from trials relatively old now, but still important, that oral PrEP is safe during pregnancy. We don't know yet about injectable PrEP and other formulations that are emerging, but oral TDF-based PrEP is safe during pregnancy. And the WHO recommends PrEP initiation in pregnant and breastfeeding women who are at high risk for HIV infection, given that no negative maternal or infant health outcomes have been documented. And we have good data to suggest that providing PrEP to pregnant and breastfeeding women would reduce new HIV infections by up to 7.2% by 2030. And without PrEP, we anticipate about 76,000 new cases of maternal to child transmission during this period, so up to 2030. Since pregnancy is a period of engagement with the medical system in South Africa, about 97% of women actually receive antenatal care during pregnancy. It is an opportune time to introduce them to an HIV prevention strategy like PrEP that is both highly efficacious and, in theory, female controlled. There's a lot of partner factors that go into PrEP use as well, which we need to consider, but in theory, female controlled. So an important strategy to consider during this time. But unfortunately, PrEP adherence rates are low in African women of reproductive age, and PrEP persistence is challenging during the postpartum transition for very specific reasons and for the obvious reasons of shifts and just differences in behaviors and challenges that come post-delivery. Early PrEP trials revealed that PrEP did not effectively prevent HIV in African women, largely due to low drug exposure via suboptimal adherence. And among women in South Africa who initiate PrEP during pregnancy, being postpartum is associated with lower odds of persistence 3 months later or post-initiation, with only about 32% of postpartum women continuing PrEP use versus 68% of pregnant women. So a really kind of substantive difference between postpartum women and pregnant women coming back for their PrEP prescriptions 3 months after starting. And we have a lot of good qualitative data indicating that life stress, disrupted routine, and concerns about concealing use have been linked to decreased PrEP persistence in postpartum women. And some data, now moving into the work that I'm most interested in, indicating that there are significant psychological barriers to PrEP adherence and persistence. So most notably, post-traumatic stress and depression can lead to reduced PrEP adherence during this high-risk period. And among women in South Africa, traumatic life experiences are driven principally by sexual and gender-based violence. In fact, intimate partner violence, or IPV, which encompasses domestic violence, sexual assault, verbal and psychological abuse, is reported by over 50% of women who seek antenatal care and is strongly associated with both post-traumatic stress and depression. IPV is one of the main pathways or avenues by which women in South Africa develop symptoms of post-traumatic stress disorder and depression. And more than half of women who have IPV experiences meet criteria for PTSD, and up to 66% meet criteria for depression. So those are really, really significant big numbers, right? And across multiple studies, we've seen that women in sub-Saharan Africa, these mostly come from Kenya and South Africa and some from Zimbabwe and Uganda, who reported post-traumatic stress experiences or depression had increased risk of low PrEP adherence. And I point out this last study at the bottom because it's the longest follow-up data that I've seen. It's pretty recent, such that women initiating PrEP during pregnancy in Zimbabwe and South Africa, 48.5% had persistent elevated depression symptoms. The study looked at different trajectories of depression symptoms, which was really interesting. And among those who had those persistent elevated depression symptoms, they were more likely to report traumatic life events and less likely to have a detectable TDF level at follow-up 1 year later. So among pregnant women, of course, we know well that PTSD symptoms and depression are associated with other negative health outcomes, including shorter gestation periods and low birth weights. So these are areas of real importance to intervene on. And really, there hasn't been much work looking at the mental health side of PrEP adherence and persistence during this at-risk group. So there are currently no PrEP adherence or persistence interventions that address mental health, which is where I hope my K23 will come in. And mental health variables. Yeah.
Sorry to interrupt you, but I'm not sure everyone on the call necessarily knows what a K23 is. Would you just give like a 1 minute spiel on what that is?
Yes, I will absolutely do that. So a K23 is a developmental grant from some branch of the NIH that funds you as a researcher and funds a specific project. So it funds you to get a certain amount of training in different areas that you haven't necessarily been trained in, and funds a 5-year-long project that will help you build expertise in a certain area. So both Maria and I, and all of the T32 fellows really are pursuing this grant so that we can sort of gain a certain amount of independence in our research domains and build expertise in these different areas, which some of us have had some training in or no training in, but it's really sort of a focus on developing expertise and running a large scale project on your own with mentorship, with significant mentorship. Yeah. Is that helpful? Okay. Yeah, so we're all seeking these grants, which are incredibly hard to get. And as I really tried to understand what is, from a mental health perspective, from a psychological barriers perspective, is preventing women from continuing PrEP use, not so much from initiating PrEP use, because there's a lot of good data on that already, but what we see significant uptake, we also see really low sort of continuation and persistence. And I think, and hopefully, others will agree based on the data that I present, that mental health plays a significant role here. And we've seen that actually with HIV medications, with antiretroviral therapies, that depression has been significantly associated with poor adherence, and that treating depression not only improves self-reported adherence, it improves virologic status, and really kind of improves overall health outcomes for these patients. So we're thinking that quite possibly doing so with women who are at risk for HIV, and at risk for other negative health outcomes associated with these mental health challenges, we can really target improve sexual health and increase sexual agency in sort of helping them move forward and planning through their pregnancies during that high risk time. So because there are currently no interventions that focus on both PrEP adherence and mental health, I propose 3 aims in a K-23 grant, the first of which is to collect some qualitative interviews with pregnant women to explore the mechanisms by which post-traumatic stress and depression impact adherence and persistence. And I have some ideas as to what those mechanisms are, but working with the community advisory board, I have a slide later on that shows the setting that I'll be hopefully working in. And sort of working with South African colleagues, I really want to make sure that my understanding of the mechanisms is fair and accurate, and that it comes from the community as well. So based on what I know and the work that my mentors have already done in South Africa, we sort of view some sort of common underlying mechanisms to post-traumatic stress and depression that are likely going on here and implicated in this PrEP adherence problem for pregnant and postpartum women. And those 2 sort of common behavioral pathways are avoidance and withdrawal. So from a behavioral perspective, post-traumatic stress and depression are maintained by avoidance and withdrawal. And these are mechanisms that underlie both of these conditions. We call them, you can consider them sort of transdiagnostic mechanisms or just underlying common elements that occur in both of these experiences and both of these symptom sets. So many pregnant women with trauma histories have post-traumatic responding, whereby they avoid situations that evoke fear or distress. And that is women who've experienced physical or sexual assault, muggings with actual or threatened physical violence, or other forms of trauma may avoid participation in sexual health services or full engagement in HIV prevention behaviors because they might remind them of traumatic events. And distinct from trauma-related avoidance, the physiological and cognitive symptoms of depression, like slowing down, psychomotor retardation, feelings of worthlessness or guilt, loss of pleasure, often lead to functional impairment or reduction in engagement in health behaviors through withdrawal from activities, and most importantly, from withdrawal to engaging in behaviors that would be helpful in terms of HIV prevention, like taking PrEP. And though, trauma and depression or avoidance and withdrawal likely affect self-care via different pathways, I think that a behavioral and skills-based intervention that's uniquely targeted to this population that addresses both of these underlying factors would likely have the biggest effect sizes and most clinically meaningful treatment outcomes, right? Rather than treating the PTSD or treating the depression, sort of understanding and finding the ways in which these things overlap, and then targeting those common factors, I think, especially in an antenatal care setting that's very busy, really kind of going for the most bang for your buck in terms of integrating an intervention that's sustainable and that could be really meaningful for this population. So that's sort of my thinking on that. Which brings me to aim 2 of this hypothetical grant, which would be developing this brief PrEP adherence and persistence intervention using cognitive behavioral strategies. I'm a psychologist. My training is in cognitive behavioral therapy. I have a slide next that kind of describes how those principles operate from this perspective, but there's a lot of evidence-based strategies that have already been shown to work in this context in South Africa in Xhosa speaking cultures that we can kind of borrow and leverage to build this intervention, and then iteratively refine the intervention through a small proof of concept study and conduct some focus groups with providers to speak to barriers and facilitators to implementation, because the key here is really developing something that's meaningful, that can actually work in context, that's not going to be something that's created in a lab and stays in a lab, right? We really want something that can be sustained. So when thinking about the CBT model, I wanted to address how we could really target these underlying factors or these underlying mechanisms, both withdrawal and avoidance and whatever other mechanisms come out in those initial qualitative interviews with participants, because I anticipate withdrawal and avoidance will be relevant, but there could be other things that I don't know yet because I haven't conducted the interviews yet. And I want to make sure that, again, it's responsive to the actual needs on the ground. So the cognitive behavioral therapy model is a validated theoretical framework for treating post-traumatic stress and depression, and that will likely inform the content of the intervention. And other successful medication adherence interventions for people with HIV, but also for people who inject drugs or people who have diabetes, have used cognitive behavioral strategies to mitigate the psychological barriers to adherence. And CBT is guided by the assumption that maladaptive thoughts and behaviors play a role in the development and maintenance of psychological disorders. And according to this model, you can see here how negative personal experiences like trauma and context, the history in South Africa, culture, contribute to the development of unhelpful thoughts and beliefs like I'm worthless, I'll never make it, my future is bleak, which then lead to emotions like sadness or fear. And then those lead to behaviors like withdrawal and avoidance, which correspondingly lead to things like poor self-care, low PrEP adherence and persistence, and back to those thoughts and beliefs in a cycle that is not unbroken or unchallenged unless we really intervene very intentionally to stop it. So, culturally entrenched gender roles, which contribute to gender-based violence, post-traumatic stress, negative conceptualizations of mental illness, likely influence beliefs that compromise PrEP use in this context. A history of institutionalized racial segregation and oppression during apartheid also may contribute to the development of these unhelpful beliefs. And again, these beliefs lead to the emotions, which lead to the behaviors, and we develop this very unfortunate cycle that continues in perpetuity without intervention. So that's the model that I'd like to use. And this is the more mechanistic model that I've been thinking about in terms of developing the intervention. So I would anticipate, again, that the intervention will likely target two pathways to PrEP adherence and persistence, the mechanistic decreased withdrawal, decreased avoidance pathway, and a pathway that focuses on behavioral skill building. So some of the strategies I might include are exercises that improve distress tolerance and coping, and to help participants build new behavioral skills, likely incorporate behavioral activation, which is a strategy to schedule activities to increase pleasure and a sense of mastery, and problem solving, which includes some basic steps, hopefully to align with individual values, which also then again break maladaptive patterns of avoidance and withdrawal. Which takes me to the last aim of this proposed grant, which would be to evaluate the feasibility and acceptability of this intervention in a pilot randomized controlled trial. So thinking most critically, primary outcomes of feasibility and acceptability are people finding this program useful. Is this acceptable? Is it feasible in context? That's really the most important thing to evaluate in sort of a pilot approach here. But thinking also about secondary outcomes like PrEP adherence, self-reported, and PrEP adherence measured through dried blood spot testing, which would be our persistence measure. DBS gives us like a look back window of about 8 weeks. So we'd be able to see how women are engaging with medication, what the levels are, and what sort of level of protection they have against HIV, because the pharmacokinetics of this differs by pregnancy versus postpartum. So really kind of understanding what's going on and if this intervention is having any impact. And then, of course, looking at decreases in post-traumatic stress and depression as well. Again, hoping for changes there. So I would hope to do this work, and I am already engaged in another project, which I can talk about very briefly, at the Guguletu Midwife Obstetrics Unit in Guguletu, which is a former township community, a peri-urban settlement outside of Cape Town that has over 400,000 residents, 48% of whom are unemployed, and 64% of adults live on less than 400 Rand per month, which is about $28. In this particular clinic, it's really active. shut down somewhat recently because of COVID for a couple of days, but they're now back up and running. And they see about 1,200 pregnant women per month, 75 of whom are HIV negative. And because I'm working with teams that are already established there, at least 500 women receiving care have already been prescribed PrEP through these other projects. South Africa has taken quite a long time to establish PrEP guidelines for pregnancy, and to sort of institutionalize those across the country, for a number of sort of administrative reasons. But now it's more available, more widely available as outside of a research context, but it's been challenging to get that up and running. So even though South Africa was one of the first countries to actually approve PrEP, they're facing challenges with implementation in this population. So it just speaks to the importance of implementation work as well. So really involved already with that group. Also have engaged with their community advisory board a couple of times for a study that I'm currently doing, which is looking at psychological barriers to PrEP uptake during pregnancy, which is sort of a different aspect of the puzzle than persistence and adherence. But for this K23 study, I would recruit women who are HIV negative, currently pregnant and presenting for antenatal care at this particular clinic, or at least 15 years of age, and have already had recent PrEP initiation or PrEP adherence challenges. And that can be either late to pick up their refill or just self-reported challenges, because we want to target women who are interested in using this tool, right? Not women who have been offered the tool and are not interested in taking it, but women who are already engaged and facing challenges. And we also want women who have symptoms of trauma and symptoms of depression. And these are pretty moderate to severe symptom presentation in these two criteria. This is a specific number for the Davidson Trauma Scale, which is a 40. And for the depression symptoms, again, moderate to severe, which is that Edinburgh Postnatal Depression Scale. And exclusion criteria listed there. I won't really get into those. But I will give you a brief look at how I anticipate designing the study, giving participants, this will be a 2-armed randomized controlled trial. And prior to randomization, all participants will be guided through an adaptation of life steps, which is a single session CBT-based medication adherence intervention that has already been used to increase PrEP adherence. And for ethical purposes, all participants will receive this session. I think it's really important that we ensure that that's available. And it's problem solving based. So it takes women through specific challenges that they've already faced and asks them to come up with a solution, whether it's related to medication storage or transportation, if they're going to visit their families in a different part of the country, just making sure that they have a plan A and plan B in terms of taking their medication consistently. And then the women will be randomized, and they'll be assessed at this baseline randomization visit with what I anticipate being 4 sessions of the CBT-based PrEP adherence intervention, ideally to align with visits as they're already making to the clinic. So it will depend on when women present for care in their gestational process, at what gestational week they present for care. And we will assess at the end of treatment, do some exit interviews, take those blood samples for dried blood spot testing, and then assess again roughly at 3 months post-delivery for every woman to ensure that we're keeping this relatively consistent across time, even though women may receive the intervention at different time points. So that is the plan for the intervention, which would take about 9 months per participant, and would give us a sense for whether or not targeting these mental health factors, these underlying mental health factors, really has an impact on PrEP adherence and persistence. And from the way I see it, based on the results of this study, we'll be able to apply for larger funding to assess the efficacy or effectiveness of the intervention, making sure that we're in multiple clinics at a time, or really ramping up the trial so that we get actual kind of data that indicates clinically meaningful change, not just suggests a clinically meaningful change if we're just looking for feasibility and acceptability at the beginning. I also think that this intervention can be adapted for other populations that face psychological challenges that are high risk for acquiring HIV, sex workers, women who use alcohol in this context, which is actually quite common in pregnancy in Cape Town. Other studies that I'm working on address that issue, and for transgender women as well. And thinking again, as we anticipate other PrEP formulations that are not yet approved for use in pregnancy, like TAF or the dapivirine ring, recently approved in the European Union, and long-acting PrEP, which includes injectable PrEP, which was more effective than oral PrEP in preventing HIV among African women, which is a study published a couple years ago, like the end of 2020. Which is new and exciting data, but again, there's no safety data for pregnancy. So I anticipate that these CBT-based interventions, or this particular intervention with CBT-based strategies, would support PrEP adherence and persistence among women with these psychological challenges, regardless of PrEP formulation. So thinking ahead again, women who need to get a monthly injection, who again have these avoidance or withdrawal patterns, these strategies will also be useful, I believe, for them as well. And that is it. Thank you so much for listening to me. I hope it was interesting, and please let me know if you have any questions. Here are a few photos from my time there. I haven't been in a while, which has made me really sad. And it's actually, we can have so many different conversations about doing global work during the pandemic, and we already have, but it's been a real challenge maintaining relationships and getting my other study off the ground. So I'm definitely interested in hearing your thoughts on that. But yeah, I'm hoping to get back in March, or at least that's the plan right now, and we will see how it goes.
Thanks so much, Amelia. We really appreciate it. Super interesting. In the interest of time and just making sure that we can allow Maria to start, if folks want to maybe write their question in the chat so that you don't forget it, that would be great. And Amelia, if there are any that it makes sense for you to just go ahead and chat the response, feel free to do that. But Maria, why don't you go ahead and get started, and then hopefully at the end we can get questions for both of you guys.
Thank you.
Alrighty. All right. Thanks for the introduction and for having me. I want to talk a little bit about something related to my work and what kind of has been inspiring to my work and thinking about what I'm doing in terms of research. And that's thinking about perinatal mental health care gaps in under-resourced settings, and thinking about the idea of integrated care in low and middle income countries. So as many of you know, I know everyone here is interested in mental health and interested in global, so I won't go into too much in the details, but I know we have a mix of experiences in terms of everyone who's here. So the perinatal period, it's a very vulnerable time for women who can carry multiple risk factors for mental illness and lack access to mental illness. So these are kind of the highest risk. And when I say perinatal period going forward, that means during pregnancy, the 9 months of pregnancy, and then up to 12 months afterwards, which is referred to the postpartum period. And the 9 months is referred to kind of as antepartum, before. The implications of, for example, there's a lot of different mental illnesses that can be triggered during pregnancy. Perinatal depression is one of the most studied and most frequently talked about, given the significant implications of it. There are a lot of obstetric complications, poor infant outcomes, and then there's evidence for offspring development impacts up through adolescence and probably beyond, but that's where the evidence lies. There's a high risk for early labor, preeclampsia, poor nutrition, suicide, and even in severe cases, you've heard news stories of infanticide. And then one of the biggest issues that we think about, I think, in psychiatry and psychology is really thinking about maternal infant bonding and attachment, and how that can really impact lifelong individuals, leading to precipitation of mental illness going generations forward. and having difficulties with emotional functioning, cognitive outcomes, and behavioral difficulties have all been associated with perinatal depression, particularly untreated perinatal depression. In low and middle income countries, women are particularly vulnerable and have much higher estimated prevalence rates of perinatal depression, but also other mental health issues. And when you look at the numbers, it's pretty dramatic. You're looking at 7 to 15% or 10% compared to 20 and 25%, and even higher numbers in some countries. For example, I'll talk about the country that my research is in Peru. The reason for this, I mean, there's a lot of reasons, but the theoretical reason in thinking about this is really you just have higher risk factors and less access to mental health. Lower socioeconomic status, life abuse, intimate partner violence, education, unintended pregnancies, and then lack of social support. And in addition, there's also a significant amount of pre-existing depression that is likely detected during pregnancy when people are doing epidemiological studies due to untreated depression going forward. Not a lot of people access healthcare, particularly mental health care. Speaking of which, as many of you know, and why you're probably here and interested, is when you think about the immense burden of illness that exists in low and middle income countries, there's really limited access to mental health care. I just use an example of psychiatrists since I'm a psychiatrist, but there's obviously lack of access to psychologists and other mental health professionals, social workers, counselors, the vast majority. When you look at low and middle income countries, or low income countries, for instance, there's really only 0.1 to 1.5 psychiatrists per 100,000 people versus high income countries where there's 6.6 psychiatrists. And of course, in low income countries, they're often in the urban areas and very, very rarely in rural and impoverished areas of the country. And when you look at surveys, even those individuals with serious mental illness, severe depression, schizophrenia, bipolar, those things, really, 76 to 85% of those haven't even received care when you do surveys of those countries. So the question becomes, how do we improve perinatal mental health care access in low and middle income countries when, one, you lack providers, and two, there's really diminished resources in these countries. So I want to take one example, Peru, which is the country of interest that I've been working in for over a decade now, actually. And he's qualified as an upper middle income country. Nonetheless, they really have significant income inequality, and there's significant geographic disparities in access to resources. So if you look at the map, you can kind of see where all of the people are, and also where all of the mental health and other medical care tends to be. And then when you think geographically, these are all mountains, up here is all jungle, up here is really distant kind of desert areas. And so similarly here, high altitude areas. So there's a lot of areas that physicians or other mental health professionals don't want to live, but also just accessing it is challenging because of where they're located. 10-hour drive up to the mountain, a flight to the jungle, it's really hard to gain any access to mental health care. Additionally, in Peru, there's a really high prevalence of trauma, intimate partner violence, depression, anxiety, and also substance use, though more primarily in men, which again proliferates intimate partner violence. Having to do both with historical elements and then ongoing poverty, both related to those historical elements, and significant immigration to the major urban areas from the smaller mountain towns due to lack of employment. When you look at their levels, for example, perinatal depression, you see estimates between 24 to 40%, which is quite high. Additionally, they lack mental health providers. From the epidemiological studies, there's about 0.57 psychiatrists per 100,000 people, so very few and limited access to providers. Despite this, the Ministry of Health is interested in mental health, and they're starting to build community centers and recommend integrating mental health care, as is a WHO recommendation. However, they don't really have a plan, and of course, resources are really lacking, so they don't have the financial backing to be able to do that. So that's one example of a country and all of the factors that play into being able to improve access to mental health care. So as I've hinted at, integrating perinatal mental health care into routine care is the recommendation for addressing care gaps in under-resourced settings. And that goes for all care, not specific, to perinatal. That's actually been a WHO recommendation since the 70s. But the implementation of that has really lagged behind. The problem that I think about when I think about low and middle income countries, we really have demonstrated integrated care is quite viable in high income countries, particularly within perinatal mental health care. However, there's really a lack of research and just implementation in low and middle income countries up to this point. And so when we think about actually implementing integrated care, which, for example, in Peru, they say this is what they want to do, they're not really basing it off of evidence from other low and middle income countries. It's evidence based off of high income countries. And as we all know, if you lack the adaptation to a different culture and the adaptation to a significant difference in resources, it can be really problematic. For those of you who don't have experience with integrated or collaborative care, the idea is that you utilize non-mental health specialists, for example, in this case, obstetricians or midwives, to manage, mild to moderate depression. And then you might use what we call step care, or stepping up to a psychiatrist, or a conversation even, or an email with a psychiatrist to give recommendations of what to do if the illness is more moderate or severe. And a lot of these programs in the US require case managers, additional social workers, as well as other, mental health professional specialists or nursing individuals in nursing or otherwise. So it can really take up a lot of resources. And so when you think about adapting this to low and middle income countries, you're going to have to make drastic changes. And so thinking about it from first an evidence-based perspective and not just accepting it as, oh, well, it works in high income countries, it must work in low and middle income countries. It's really something that is important to think about the existing evidence. And of course, as you all know, it's really limited by the actual amount of research that is conducted in low and middle income countries, where there's just very little research and research funding that goes towards studying elements such as this, or programs such as this. So one of the things that I thought about as Amelia had talked about, writing up a K or thinking up a K, is making sure like we really understand before proposing something what evidence we have already, and what have people tried, what have people not tried. And so that had led to doing a systematic review to really characterize and assess the effectiveness of these perinatal mental health care interventions, specifically that have been integrated into routine care in low and middle income countries, in thinking about this ultimate goal of improving maternal mental health and infant health outcomes. So we conducted a systematic review by PRISMA statement, which is just the rules of how to do a systematic review for those of you who don't know, and looked at specifically controlled trials of structured perinatal mental health care interventions that targeted depression or anxiety, as those are kind of the common mental health disorders that we think about in throughout the world, and specifically those that are in routine clinical care settings in low and middle income countries. The more complicated search, but the general terms we were looking at are mental health, low and middle income country, perinatal, mental health services, and integrated care. We were looking specifically for women in the perinatal period. So again, as I described earlier, that's pregnancy and then 1 year after delivery, and looking at looking at these structured interventions that I mentioned, and didn't just limit to obstetric settings, because as many of you know, healthcare in low and middle income countries can occur in many different places, whether it's specific HIV care clinics, primary care, pediatric care. And then looked for primary outcomes of changes of depression, anxiety, and as well as some secondary outcomes. And then we had excluded depression, bipolar, substance use disorders, just to keep it simplified to depression and anxiety. Obviously excluded high income countries, and then excluded those that provision of the initial care was done by mental health professionals. So we wanted somebody who was a non-mental health professional to be the initial point of contact for these patients. If they were stepped up to somebody else, then that would be within the realms of integrated care. And we these were independently reviewed by the two authors for inclusion, and then full text articles were additionally reviewed, and data was extracted along looking at study location, design, target population, intervention, etc. For the sake of time, I'm not going to go through all of those, but talk more of kind of the results and the findings. So this is how we went through things. We had 2,384 articles to start with, remove the duplicates, screen the abstracts, pulled those that we weren't able to retrieve, though most of the ones that we weren't able to retrieve were pretty likely to be excluded ultimately. And then ultimately ended with reviewing 60 full text articles and finishing off with 20 in the end. With a lot of, I think really interestingly, notably, a lot of the studies might lack a comparison group just due to the resources of the research study, which led to exclusion, as well as really trying to define what does integrated care mean, which I think was one of the kind of the key takeaways in this entire search, is thinking about how we define integrated care when you're looking in low and middle income countries versus the more structured model idea of high income countries. So the countries that came out with, of the 20 studies, there were about 8 nations, which again, I think also highlights where research occurs, and kind of the geographic confinement sometimes of both where research groups exist when you're thinking about global mental health, as well as where resources might be more available or interesting in researching global mental health may exist. One of the key points, I think, in thinking about this is looking at the intervention type. So most of the studies were looking at adapted counseling, CBT, problem solving, group and individual counseling, and psychoeducation. So that took up the vast majority, 40 and 25%. There was a very small percentage of integration of exercise, mindfulness, and relaxation training. And then very few, about 15%, actually included some element of what we might call traditional integrated care, so stepped care. And then most of those were also combined with counseling and psychoeducation. So it was mostly multi-pronged approach. And very few, again, really included any sort of pharmacotherapy for depression. When you look at the target disorders, most of the studies we found were targeting perinatal depression. And as I mentioned, it's more commonly, it has been studied overall. And then some looked at combined anxiety and depression, though a lot of the primary outcomes still remained changes in perinatal depression. Interestingly, about 65% of the studies were looking at prevention rather than treatment of depression. And so they were screening with depression screening or anxiety screenings, and weren't only doing the interventions with women with depression or who were scoring with depression, and very few followed up with a diagnostic assessment. As many of you know, screening tools are not a diagnosis, and the actual diagnosis is clinical. And so really the kind of the takeaway there is a lot of the focus in low and middle income countries is not so much on treatment of depression, but more of kind of this prevention strategy and really looking at all comers, which isn't, it's different than high income countries, but when you think about the prevalence rates, it makes a lot of sense because there's such high prevalence that you're likely to get a large amount of individuals and potentially prevent a lot of perinatal depression for really high risk groups. The intervention personalities included mobile phones, peers, community health workers, nurses, midwives, and obstetricians. The primary implementation location was mostly in healthcare centers, though I think it's notable that about 20% of these were implemented in homes, which you think, is that still integrated care? But I'll talk a little bit about how when you're particularly in low-income countries and rural areas, primary care can often be implemented in home settings rather than in clinical settings. I think an example of this is in Pakistan, where community health workers can be the primary providers for healthcare and go to homes rather than individuals going to clinics. There's a number of different scales that were used, PHQ-9, the EPBS, which is the Edinburgh postpartum depression scale. As you can see, you've probably heard or seen some of these, but it's a huge variability there, which again, I think is a highlight of something you often see in low and middle income countries due to what's been adapted to the country and what works and what has been used before. Is a lot of times where we go with research is what exists, what's been adapted, what's been translated. And then overall, 19 of the 20 studies we looked at demonstrated improvement in outcome scores in depression or anxiety or both for the intervention groups. The only one that didn't was the exercise intervention. So thinking of time, I'll go kind of over the key points pretty quickly, but there was pretty large variability, as I mentioned, in the intervention types. As you guys saw, and mostly, really these psychosocial, psychoeducational interventions and very few traditional, if you will, integrated models, such as, the stepped care idea, which is pretty common in the US, or the collaborative care idea, where you have like a case manager monitoring all the patients and their scores and the changes. And very few also included pharmacologic interventions. Most of them were targeting prevention or very mild depression. In fact, majority of the studies excluded anyone who had more moderate to severe scores in screening or who had any sort of concerns. And those people, sometimes they would automatically just send them to a higher level of care and exclude them from the study altogether. And again, as I mentioned, the measures in depression and anxiety are quite variable, which is not infrequent in research in low and middle income countries because of what we know has been adapted previously. I think one of the key points in looking at this is that a lot of these studies really had adaptations that were done in low and middle income countries, and really to overcome the barriers to implementation in these under-resourced settings. For example, primary care done in the community in low income countries versus more traditional clinical settings just makes more sense. And that's how the healthcare systems are often set up, where you get care at home versus walking a huge distance to the nearest local clinic, or just not even having any accessibility to a clinic anywhere nearby. The use of group interventions, peers, and mobile applications, though mobile applications primarily in more resourced settings like middle income countries, were pretty common, and again, are not things you typically see in high income country interventions. And then there was a lot of addressing of psychosocial risk factors. So psychoeducation might have focused on things like partner relationships, intimate partner violence, and other elements, including socioeconomic strategies to help improve the state of these women. Which is, again, I think a little bit different than what you see in high income countries. They're really focusing more on that piece. And then of course that we talked about the cultural and language adaptation. So the key points, last slide to take away, is that yes, integrated perinatal mental health care can be successfully adapted to low and middle income countries, though may look very different than what we think of as integrated or collaborative care in the US or other high income countries. Most of the current interventions really miss higher risk populations, individuals with moderate to severe illness, and the current interventions are really have limited use of these stepped care designs. So there's not much beyond the psychosocial intervention. If people have more severe illness or that's not working for them, there's not really a step up. It's kind of like with these interventions, that tends to be end of the line there. And very few are really looking at medications which can be really successful in treating moderate to severe depression, for example. And then I think there's really this piece about reverse intervention where high income countries can really learn from low and middle income countries, particularly in communities, thinking about how to do care in community settings, using alternative interventions like mobile apps, peers, or group interventions rather than individual. And then really addressing the psychosocial risk factors that are contributing to severe depression or anxiety. And all of this leading to what I'm hoping to do and applying for in this grant K idea, but being able to think about models that are more kind of traditional integrated care, but that are adapted appropriately to the country, and thinking about these more moderate to severe cases and pharmacologic interventions, which really we don't have evidence for up to this point in terms of adaptation. So thank you.
to any and all questions. I think there were some questions in the chat that Amelia answered directly, so thank you for doing that, Amelia. But any follow-ups for Amelia or any new questions for Maria, feel free. All right, I have a question for Maria. I'm curious, from all the things that you read, so some 40 something studies, was there one that was sort of a best case scenario that you think might be most directly implementable in the context that you're describing, or is it going to be a totally de novo type of system that you're thinking to generate?
Yeah, I think it just really highlighted for me something in support of the idea of really thinking about these more multi-level integrated care programs, because again, a lot of the research and a lot of what people have done are these psychosocial, psychological, which are great, and really address and things that the WHO is really putting forth, and they address the mild cases and can really do a lot for prevention and other elements. But I think you're just missing this huge piece, and there were a couple newer studies that are coming out now where individuals are doing more of this multi-pronged, stepped up kind of care, where they start with the obstetrician or otherwise, and then if they're not feeling they're able to handle it, and then you go to the next level of a psychologist, or you go to the next level of psychiatrist. But training, I think, is the key part that comes into this, and this is what I'm very, very interested in. Is you have to be able to train non-mental health professionals. And I think this is a piece in Peru where they, for example, they built these community health clinics, and they're lovely, and people go there and they start medications, and then they send them back to the primary care providers in these tiny little postas, and there's no mental health support. They don't have the medications, and the primary care doctors don't know how to titrate them. And so you kind of have this gap where that needs to be covered, and part of that has to be in the training. And so I think that those are the two things I would think about, is the idea of training, and then figuring out how to actually scale up care in a way that's, you're not going to just, people will kind of drop off without getting the care they need.
Yeah, that makes a lot of sense to me. I think we see it, I see it in my work, and when I was doing pediatric integrated care here. And I think I think everyone's very well-meaning, but it's about training the providers now, so that 5 years from now, the whole process is working better. So that makes a lot of sense to me.
Yeah, that's in part why, I mean, I didn't mention this, I don't think, but why I hope to use lay counselors, and why we are kind of moving toward non-specialist focus. My mentors have been involved in studies now where they use nurses as interventionists, and we're going now to lay counselors as well, just to really avoid tasking the psychiatrists, psychologists, and the medical doctors who have so much more on their plates and can't really handle this. But I think in part, like, the building a sustainable intervention in an antenatal context, whether it's an individual intervention or a structural kind of embedded care system, we have to make sure that we're building sustainable training models, and that it's not going to be me training the lay counselor from the US for the entirety of the 5-year project, right? I have to train someone else to do it, and in collaboration with like counterparts on the ground, make sure that everyone is being trained so that they can continue the work. It's not, I mean, we can't build those kinds of systems. They're just not sustainable.
Yeah, and I think the ongoing supervision piece is also one that it's really important to me. Something we take for granted, I think, in training, particularly in psychiatry, where you do supervision all the time. But if you're an obstetrician, you've never treated depression, you get one training course and they're like, go, what do you do when you have questions, right? Or what do you do when you have a more complex case?